Okay, I'm really sorry. I have some technical issues to increase the students' number in Zoom, so I will send the link of YouTube live, so then students can join to the YouTube live. Okay, so quickly I'll share those link through the. Okay, quickly I'll share this one. All right, all done. Sorry for delay. So you all can join through the YouTube as well because uh, uh, I couldn't increase the number of students through Mora platforms. You use Zoom. I don't know what is the reason. Anyway, right. So good evening to you also. This is 2 hours introduction about the viva class. Okay. So today what we are going to do, I'm going to teach you how to take the history in option gynae practice. So this is most important part for your part B and part C, not only part B and part C, also for your entire career, right? So once you become a doctor, until you retire, even until you die, you are going to take history, examine the patient, and plan out your management and treat. So what you have studied so far is your theory, but this viva is actually what we're going to do is we are going to apply that knowledge into the patient. So this is the most important part, and you should be able to identify the real problem and think as a holistic manner and plan your management depend on your background knowledge and the guidelines. So when you go to the viva class or viva exams, they are not expecting very minute theory points for your exams, right? So for the MCQs, of course, you need to know those theory minor things, but in viva it's not like that. So how you are going to apply your knowledge to the patient, so that is the most important part. So most of the students failed in the exam because they don't know how to apply that background knowledge into the patient. So here, more than that your knowledge, so there are so many factors playing a role in your exams, right? So obviously you need to know, or you need to know how to communicate with the patient. right? So because here, when you go to the theory class, so theory exams, they are providing the information. A 32-year-old mother of two presented in a period of amenorrhea at 38 weeks with watery vaginal discharge and abdominal pain. So here, all the information has been given to you. So you don't need to know anything from anyone. So you know the information, so you can think about your management, you can tell your answer. But in viva, it's the other way around, because the person who is sitting in front of you, it's not a medical person. She does not know. If it is an obstetrics or gynae, it's she. But even though if it is a medicine or surgery, whoever in front of you, it's not a medical professional. She does not know what to tell, what not to tell. She does not know whether the information which she is giving to you, it's important for her management. You got the point what I'm trying to say. Patient might telling something to you, but it's not relevant for you to decide your management. So as a medical professional, what is your aim is to find out the most important relevant information for you. If something lacking, you need to ask some further questions to gather that information to plan out your management. All right. So this is an art. So you can't do it overnight. So you need more practice. So the first thing is the communication. So if you don't have a good communication skill, if you can't talk very nicely, so it is going to be a problem, because you will not identify the problem. So then you will be in trouble. Second thing, how you are correlating the information and how you are planning your management. Right. Third one, your examination skills to identify the relevant problem. So in obstetrics or gynecology, the examination, you are doing only abdominal examination or vaginal examination or speculum examination. But in case of medicine or surgery, you need to auscultate, identify murmurs. So your examination skill play a role. So reading the book repeatedly, it's not going to work. So your communication, your examination, your way of organization will help you to pass the exam. And finally, for the exam, so these are definitely needed for your clinical practice as well. But for the exams, okay, for your exam, your presentation skill, how you are going to present, how are you going to manage your examiner? The person who is sitting in front of you is a medical professional, your senior. So the examiner always is assessing you if you become a house officer, whether it's safe to keep you as house officer. So if Delshini wanted to become house officer to me, so I'm assessing her here. If she become a house officer to me, whether is it safe? Is she know the stuff? Whether I can go home after 4 p.m. Right? Otherwise, when I'm doing the class at 9:30 nighttime, so if she's doing some bull, then I can't do these classes. I have to stay as a house officer in the hospital. So always the examiners are assessing that whether is she safe to work as a house officer, right? So always that is the basic assessment, especially in ARPM, right? So because they are not going to give you a gold medal, they're not going to give you some kind of postgraduate or something. So you're not a consultant. You don't need to study or you don't need to answer like consultant. Yeah, because most of the management plan will be made by the consultant. So most of the time students are thinking, oh my God, I forgot to tell that investigation. I forgot to tell that management. That's why they failed. It's not really. The real reason why you failed, you made a mistake in very basic. So if you can see my pass rate for in the past, so we are having more than 95% pass rate. You can ask from your seniors. So most of the students who come to my class, they almost pass. The simple reason, what I'm trying to teach to my students is how to approach the patient, how to gather information, how to organize the history, how to present, how to use the background knowledge rather than just giving you some notes. And so of course, if you come to my class, I'm giving the history or English version, Sinhala version, Tamil version. So don't memorize anything. It will not help you, right? You are not parrot. Just telling something in the class. Okay, tell me LRMB, EDD, name, age. So definitely it's not going to help you. So you people are thinking, if I study these things, it's enough. It's not. It is a personality development, right? So who come to my class, so because I have seen last time also, every time I'm telling, so still why I am having this 90%, still that 10% is failing, because 10% of people are just registering to my course and coming here, going there, and commenting and not concentrating. So if you come to the class, please concentrate. Please try to understand what is the fact I am telling. Rather than don't go and sit in front of the books and read those things. So you are not going to achieve anything. Whoever just try to understand the fact and how to approach the patient, that is the fact you need to know for passing the exam. Right? So your soft skills, here they're assessing your soft skills, your communication, your way of communication, information gathering ability, organization. So I'm going to teach you that one today, how we are going to take the history. Because in the viva class, it's not the theory class to teach you the theory stuff. I will teach you the theory stuff here, which is related to the viva. Because already you all studied theory with me, you know the stuff. You are having enough knowledge. You don't need to spend much time with this theory stuff. Here you need to know how to present. So especially what I am going to do, or what I used to do in viva courses, I do a lot of case presentations. That is helping a lot for the students. Case presentations. You know what is that case presentation? So what we do, so even last time I think we have done 16 or 17 case presentation classes, free classes. So students who attended to my stage 1, stage 2 are allowed to come to the case discussion. So this time also we will do new case discussion. So I think this is the third online course after this COVID. So with the first COVID, I think we have 14 case discussion. Second course, we have another 14. So this time also we'll do. So I'll upload that too. So then you will have like 30, 35 case discussion in the platform. So you can watch that 35. So if you watch that 35 cases, so how to take the history, how to do the examination, how to organize history, how to present history, how the examiners will ask the question, how to answer the question. So those kind of things are in the case discussions. So if you watch that, so please don't read anything. Just come to the class, see what I am telling. Oh, just watch the class in the platform and just watch the case discussion. So this time what we will do case presentations. Whoever would like to present the history to me, you can present. I will guide you. I will tell you what are the mistakes you are doing. Because keep it in your mind, at the end, on the exam day, you are the one going to present the history to the examiner, not me. Right? I'm not going to come and present the history. You are the one going to present the history. So you need to get practice how to present the history to the examiner. You need to know that. So you need to have that practice. Do you think without any practice at the overnight, at the exam center, you can present the history very nicely? Obviously, no, you can't. It's kind of drama. You need lot of rehearsals. You do mistakes, correct your mistakes, do mistakes, correct your mistake. Then only you can perform very well at the exam hall. Right? Then only you can present very well at the exam hall. So this is going to be a coaching session rather than a viva course. I'm going to coach you. I'm going to train you how to approach to the patient. This is not only for the exam, also for your career. When you do private practice, when you do house officer work, when you practice throughout your career. So if you want, I can show you some SMS, or I can share some SMS. The students who send those message after starting the internship, sir, really now we realize what we have studied, it's helping us when we are practicing as a house officer. We know how to present to the consultant, because in the exam you are going to present only one case. That's okay. Once you pass the exam, when you become a house officer, every vote round you are going to present minimum 50, 60, 70 patients to your examiner, your consultant. So you are thinking only this one case presentation to the exam. Of course you will pass, but once you pass the exam, you are going to get scolded by the consultant in front of nurses, in front of minor staff, in front of medical students, in front of other staff, in front of patients. You will get scolded by the consultant because you don't know how to present. You don't know how to get the information. You don't know which one is important, which one is not important. So that time you will realize, why did I study medicine? Because I came through that path. I was the house officer one day. I was the RHO one day. I was the SHO one day. I was the register one day. I was the senior register one day. Now I'm a consultant. So I came the same pathway what you are going to do that. So when your consultant is scolding in front of everyone, so during the vote round, you are getting scolded by the consultant, you are getting scolded by your SHO. Then when you come to the vote round in the night in front of the patient, so that patient, what the patient will think about you. So you can't face the patient. So always you need to think about that and develop your skills. So when the exam, or your consultant doing the vote round, you are presenting 50 patients. So if you know that art, if you know how to approach the patient, if you know how to identify the problem, if you know how to present your examiner or your consultant, if you know how to do the basic management, here the examiners are expecting you to tell about the basic management. When a patient presented with regular heavy menstrual or irregular heavy menstrual bleeding, got admitted with tachycardia and hypotension, they are not expecting you to answer like uterine artery embolization, GNRH analog, myomectomy, hysterectomy. They are not expecting that from you. If you know that, that's better. Those are the information needed for your MCQs. But as a house officer, what you want to know, what you want to answer, I will do the full blood count. I will put the cannula. If hemoglobin is less than 7, if the patient is symptomatic, I'll transfuse the blood. That is the life-saving event. That is the house officer's duty. Not to decide uterine artery embolization, not to decide hysterectomy, not to decide myomectomy. That is a consultant decision. First of all, you all have to know that what as a house officer you need to know, what as a consultant you need to know. When you go to the viva exam, just think rationally. The examiner's expectation, will it be a consultant questions or house officer's question? Should be a house officer's question. They are expecting if you are a house officer. So without putting the cannula, without checking the hemoglobin, without transfusing the blood with hemoglobin of 4, if you answer like uterine artery embolization or hysterectomy or myomectomy, is it a correct answer? No. So when the examiner asking, okay, now this patient, you're the house officer on call. Now patient came with you, and on the examination, my internet connection is unstable. Yeah, fine. So on the examination, there is a mass. It's 20 week size uterus. Mobile uterus is look like fibroid. What is your management? Don't tell. I will book for an ultrasound scan to confirm the fibroid, and if the fibroid is intramural, then uterine artery embolization. No, dual answers, isn't it? So here you need to know which one I need to do as a house officer. If I'm the examiner, or even just imagine if you are an examiner, If a junior is answering like this, a patient with symptomatic anemia got admitted to your ward, but you are not bothering about the anemia, you are not bothering about the hypertension, you are not bothering about the tachycardia, you are thinking of, because always what we are thinking, examiner has told there is a fibroid. So you want to tell to the examiner, I know what is the management for this fibroid, because you have studied. Overnight, early morning, you are studying, you paid a lot to study, and your teacher has taught you. If it is a fibroid myomectomy, so then you need to tell that. It's useless. That is not the answer the examiner was expecting you at that moment. So this is the viva, this is not the MCQ. So if the MCQ class sometimes, so fibroid uterus, so what is your preferred management? So then yeah, you can tell about that. But the viva class is totally, viva exam is totally different. So here you need to learn what is the answer I need to tell, what the examiner is expecting from me. Right? So most of the classes, you can see, I'm teaching the principle. So what you need to tell, what you should not tell to this case. If you see this case discussion, every question, what I'm telling, what I'm asking, what I'm enforcing you is the exam points. So if you watch those case discussion, if you attend to my case discussion, then obviously when you go to the exam, you will not get any new questions, because the examiners are going to ask the simple thing, their day-to-day clinical practice. Except the consultants who are involving with the teaching, or some consultant might read something continuously. Most of the clinicians, right, are not reading, and they are not updated with the latest guidelines. But they know what is the most important management relevant to the guidelines. Right? So yeah, I was just asking, you studied anatomy in your first year. Are you reading anatomy still? No. But you know the anatomy. If somebody asks what is the pulse rate, you are checking the radial pulse, because you know the anatomy. You know the clinical relevant of the radial pulse, radial artery. But you are not studying. So you are not knowing the minute things about radial artery now, but you know about the basic knowledge about the radial artery. So like that, most of the clinicians know the clinical fact with the clinical experience. They are doing the practice. When they are coming as an examiners, this is not the theory exam. In the theory exam, one person who is setting the paper, he is involved with the teaching. He read all the guidelines. He made the question depend on the guidelines. So you all are expecting to know that guideline. But when you go to the viva, there are plenty of examiners. Every center's 20, 25 examiners are coming. So roughly throughout the Sri Lanka, 100, 150 examiners. Do you expect all these 150 examiners are involved with the teaching activity? No. But they are good clinicians. They know how to manage the patient. What are the things you need to know as a good clinician? So when they are coming as an examiner, they will ask the clinical points rather than your theoretical minor stuff. So always you need to understand that fact. So when they are coming for an examiner, so you need to answer in clinical background rather than your theoretical background. Of course, you need to know those theory. Of course, you need to apply your theory knowledge, but you should, according to the guidelines, this is how, so I will do this. No, man. Whatever the guideline, it's guiding you. This is the clinical scenario. Patient is dying. So first I'll put a cannula. I'll give blood. I'll make the patient stable. Then only so then you can, so if you are a junior, so if you are if Delshini is my junior, my house visa, I would be happy if she answer like this. So this patient is tachycardic and hypotonic, hypotensive with symptomatic anemia. So I need to stabilize this patient. First, I will put a cannula, take blood for full blood count, and group and save. I'll preserve minimum 4 pints of blood. I'll contact the blood bank to issue 2 pints of blood. I'll transfer the blood immediately. Then I'll get the opinion from consultant for the further management. Who is going to decide the management? Consultant, not you. So when it is a viva, that is like that. So GDL, I'm always telling this example. So GDL, if you don't know how to advise a patient to do a OGTT test, even if you know how to titrate the insulin and how to adjust the dose of insulin, it's useless. Because entire management, it's depend on the OGTT, nothing else. If you are not instructing the patient to do OGTT in proper way, your results is wrong. Sometimes you might miss the diabetes, sometimes you might overdiagnose the diabetes. Even without diabetes, because of your fault, if patient is on prednisolone, you are not checking that, you just did the OGTT positive, you are treating as a diabetes. But honestly, it's a diabetes. No. That is because of the prednisolone. Right? So, bronchial asthma patient, short-term prednisolone for 3 days. You did the OGTT without checking that. Blood sugar is high, then you started insulin. What will happen after 2 days? She will develop hypoglycemia. So your entire management is getting wrong because of your basic skill. So if blood sugar is high, whether insulin or metformin, the decision is by the consultant. But in this patient, when they do the OGTT, consultant is not going to advise the patient how to do the OGTT. Who is going to advise to the patient how to do the OGTT? How to collect the semen for seminal fluid analysis? Who is going to advise to the patient? You. If a patient has a sexual intercourse previous day, night, and early morning, he is giving the semen, then he might have oligospermia. Then you are doing all the management for the oligospermia. It's not oligospermia. It's a wrong technique to collect the sperm. So the consultant is going to give the management plan depend on that results. So that results is most important. So that is mainly done by the house officer. So if I am the examiner, if you don't know how to advise a patient to collect SFA, if you don't know how to advise a patient to do OGTT, you should not pass. You have to fail. Why? Because I am going to give the management plan depend on your investigation. So if you don't know that basic stuff, I will be wrong because of you. This is how all the examiners will think. How can I give a management plan with this wrong house officer's decision? Because the consultant is not going to assess every patient in every aspect, because if the consultant wanted to assess the patient from A to Z, he can't do the what-on. That's why he's having juniors to do some works. If that junior doesn't know how to assess the patient, it's not possible. This is the reason most of the people fail the exam. This is the reason most of the students who are coming to my class pass the exam. Because everybody knows how to assess the patient. Everybody knows what I must know. There are some things you must know. There are something nice to know. But most of the medical doctors who are going for a licensing exam, they are thinking the examiners will get impressed when you tell some sophisticated things. Really not. It's really not. Okay? So you should not do mistakes in must know things. So throughout this viva class, we are going to study that one. What are the things you must know? What are things you need to know to pass the exam? Okay. So this is going to be like 14 classes. So stage 1, 7 class, stage 2, 7 class. So this time I'm planning. So of course, this is a small batch. So what I'm going to do is I'm going to do two things. One, so the first time when I do the viva class, I have done these classes with the patients and demonstration and all. So for the small batch, bringing the patient is quite difficult. So to get that access, we'll do that patient demonstration and proper things with the viva class. Same time, that day night, 9:30 to 11:30. Say if it is Thursday night, 9:30 to 11:30, I'll do that particular class again as a live class. Two reasons. One, give an opportunity to ask questions. Second, I have to be updated with this. Otherwise, if I'm doing the Zoom class every time, restreaming, resuming, I also will forget you as you. So I need to continue to teach. So I'm going to do the live class as well this time. So that's why I have put live class plus resuming. So resuming is obviously I'm going to resume the previous class as well because that is quite elaborated with the patient's demonstration. So meantime, so we'll do the live class as well. So because we have time, so we will do the same class will be done as a live as well. Say if it is a obstetric history taking, so you will have Zoom resuming as well as you will have a live class. So students who join to my class, I will update those things through the WhatsApp group when will be the live class. So we'll do the live class and the resuming as well. Okay. And the practical session. So I usually do the first time we have done in Mullaitivu, second time we have done in Mullaitivu and Kalabovile, second time we have done in Tellipalli and Kalabovile. So this time I'm planning to do it in Colombo because of course it might be difficult for you to come to Jaffna or Mullaitivu or somewhere other part because of this fuel issues, and isn't it? So I feel like if I'll arrange something near to Colombo, maybe Colombo Castle somewhere, or we can arrange the session in private sector as well. So usually I don't arrange the private places because the obstetrics and gynecology is quite it's litigations, right? So bring the pregnant mothers, vaginal examination doing outside the hospital setup. Yeah, so we might be in trouble when we do those things, isn't it? So even when we are doing the examination, if IUD occur after 2-3 days due to some other reason, patient might claim because of the examination if everybody was pressing the baby, that's why baby has died. So yeah, so then it's very sensitive one, not like your medicine or pediatric or surgery. It's very, very sensitive and litigation. You might be in jail either. So then we don't want to take that risk. So that's why I'm always doing those classes in the hospital setup. So then you are safe and myself safe, right? So I'll let you know how the things will go. So I'm going to do that one in nearby Colombo, maybe in later part of in September, like that. So that is how I'm thinking. Depend on your exam, we can plan about that. So before the practical sessions, we'll complete this viva class. So then everybody will know about the approaching the patient, taking the history, examination techniques. So I have a good examination demonstration videos which I have done and it's recorded. UV prolapse, speculum examination, abdominal examination, obstetric examination and all. So those are available in my platform. So once you join stage 1 and stage 2, you will get the access. Is it possible to get exam in August? Definitely not. Probably in November. The exam will be in November. I don't think it will be in August because it will take time. So just use your common sense now. Now still your results not out. So after that they have to announce the applications. That might take 2-3 weeks. Then after closing the application, another 2-3 weeks. Then every stations they should be. So it's not like your theory exam. So theory exams, they could have the exam in a single day with for all candidates. It's not like that. So there is a possibility one station might be early, one station might be late. But every station depend on the feasibility, only they will give the date. So I don't believe till October or November. So it should be in the November. It might go up to January either. We don't know, right? But it's usually, this is our experience. So usually it's take long durations. So last time also exams started in March. Some students had in May as well. Later part of April, May, early part of May. So the duration is almost like 3 months, 2.5 months, not in a single day. The one station is in, I think Peradeniya was in March, Ragama was in May. So it's bad luck. Some students will get early, some students will get late. So that's, but I don't think it's in August or September. So if November, most likely we won't be able to with the main intake with October. No, I don't think they will take the main batch in October. That will be in the November end or maybe December. So that's why I'm telling. So because most of the time, so I don't think without you, they won't take you, right? So they will conduct the exams and all until if there is any court case or something, right? Even for your theory exam, everybody was telling the SLMC is going to do the exam in July 4th, and finally what has happened, it's later part of July. So that is how it is. Exam hall, the chief promised to have September first week. It's less likely. First week is not possible. We'll see. So we have enough time. You don't need to think about the exam schedule. So we have enough time. We can prepare and further. All my classes are uploaded in Maura Education. So once you join, you will get that access. It's 24/7. You can watch whenever you are free. You don't need to worry about the electricity. You don't need to worry about your convenient time. You can just watch it and you can finish it off. So then I will do the live class. That time you can come after watching that class. All the classes, examination videos also will be restreamed, right? Yes, of course. All the classes will be restreamed, resumed. All the classes will be conducted by the live class as well. So I will do live as well this time. So live and also resuming, both will happen. So students who don't have the access to Maura Education because of your inavailability of your laptop or MacBook. So if you have only mobile devices, then you can, if you have any issues to access those classes, you can access those classes through the Zoom, right? So I will do the live Zoom classes as well as restream as well. So even the examination, even the when you join to the emergency session, of course you will get this instrument demonstration as well. All the instruments, I have a video demonstration, very nicely developed video demonstration. So every instruments and the usage for your viva. So then you don't need to worry. So that's what I'm telling. If you come to my class, you can pass more than 90 to 95% if you are really interested. If not, I'm really sorry. So just register to my class and going here and there, not concentrating, and don't spoil my name. We went to Rajend's class. Don't tell that. Okay. If you come to my class, please concentrate rather than thinking, is it necessary for the exam? Is it too much for the exam? No. I know which one is important, which one is necessary, which one is not necessary, right? So, so you need to know, because yeah, I will let you know the students who wanted to participate the clinical session. I will let you know. So how the things will go, right? Okay, so this is our study plan. So the live Zoom class, resume class, clinicals before the exam. Meantime, we'll do the case discussion. You can watch the previous case discussion in Maura. The live Zoom's case discussion will be conducted. So I'm expecting you to present the history, right? So we will discuss. I will be act as a patient. I will act as an examiner. We will bring some patient. You can take the history from the patient and you can present, right? So last time also we tried and achieved a lot. A quite number of cases we did. We did some individualized case discussion as well. Yeah, hello Abira. After a long time, right? So I did individualized case discussion as well. Like some students are having some difficulties, so you might feel shy to present the history in front of everyone. So then we'll do like a group discussion. So last time we tried but couldn't do for each and everyone, but I did for some of the students. So this time also we'll do that. So if we have enough time, so because last time what happened, so the Peradenia, the students who had the exam in the March, I couldn't do because of the short duration. But the student had the exam in the last time, the May students, I had the time and we could do some individualized case presentations. So we have done that, and some students did. They present the history and record it and send it to me to through the WhatsApp. So then I have given the opinion. So what are the things you have to tell? What are the things you missed? What are the questions they might ask? So this time also we'll do, because it should be individualized care to make you to pass. So ultimately, we both are having same aim. What is your aim? You need to pass the exam to become a doctor. What is my aim? I have to make you pass to maintain my pass rate. That's it. Okay. So we both are working together for the same aim. So if you fail, that is not good for you, not only for you, also for me as well. Because proudly I'm telling every time, I'm having 90 percentage, more than 90 percentage pass rate. So if you people are not passing, then I can't tell that. So honestly, before my arrival to ERPM field, the overall Observatory pass rate was 30 percentage. Now it's more than 75 percentage. So I can proudly say this is because of me. Yeah, of course. Yeah, of course. Because this was the history for a long period in the Observatory history. It was 30 percentage pass rate. Now it's 75 percentage overall. Still, why it's 75? Some of the students not coming to the class, because of them only it's 75. Those who are coming to my class, it's 90 percentage. So I can tell, because I'm the one contributing to bring that pass rate to 75 percentage. Now, Observatory, it's not the barrier for the ERPM exam. Earlier, Observatory was the barrier for the ERPM exam. Most of the students were stuck. They couldn't do the internship because of the Observatory. Now it's not. The scenario has changed. Now, most of the students are passing, but still some students who are coming to my class are failing the exam because the language barrier. When a single student go to Jaffna, Batikalo, when you get a Tamil patient, sometimes if you had a bad examiner, if they are not helping, yeah, I'm sorry, I can't help that. You need to learn language, but that is a poor examination setup in Sri Lanka, because I'm always telling language should not be a barrier for a candidate. So if you are a single student, they have to provide single patient. If you are a Tamil student, they have to provide Tamil patient. So I don't know why this system is, but that is the system. Some students are failing because of the language. Some students are failing because of the examiner's mood. So I can't help on that. So you need to prepare that as well. Okay. So don't think too much. So I will help you to pass the exam. Okay. And one more. Yes, we'll make Abira co-cost. Perfect. Right. So, and one more instruction. Now, with the more education, so the people who are working in academic sector all over the world, now we are going to launch some kind of academic activity, mostly free academic activity, right? So aiming to prepare AMC, PLAP, USMLE, MRCOG, MRCS, MRCP, postgraduate selection exam in Sri Lanka, everything. But what we are going to do, we are going to do some regular teaching activity through the Maura education as free, right? So it's not anything related to you or something. So I'm doing observation gynae, that is different for ARPM. So this is the Maura education continuous study program. So we are working for a long period on that. Probably we are starting this educational work from 15th of August, right? So the aim is to provide some educational activities through the Maura education as a help to not only the students, it's actually basically they are targeting the doctors who are working in Sri Lanka for their licensing exam, for their CPD. So maybe after 2 months, they are going to provide CPD certificates when you are attending those classes, right? So some seminars, webinars, when you attend, you will get the CPD certificate. So you can keep that certificate with you. You can add on your CV. That will give you a CPD points. Okay. So what I'm thinking is, as we are starting for these doctors, I'm trying to give that opportunity to my students as well, those who are studying with me. So I'm trying to convey this message to you, your seniors, your juniors. So please add those students to my relevant university group, my Telegram group. So then only I can share those information through those group. So probably coming 15th of October, we are starting with ethical practice in obs-gynae gynae. So that topic is we are not aware about that in Sri Lanka because we don't much practice about the ethical consideration. But now it is becoming more popular. And when you do the PLAP, when you do the AMC, when you do USMLE, they are concentrating more on the ethical practice. When 16-year-old girl requesting for contraception, what are you going to do? 19-year-old girl requesting for termination of pregnancy, what are you going to do? A 21-year-old girl diagnosed to have HIV, the boy, she came with boyfriend. How are you going to counsel? Are you going to do the counseling with the boyfriend or not? So those kind of ethical consideration, we are not aware about that, right? So we are not aware because we don't come across those kind of things in Sri Lanka. So here, the Sri Lanka is what we tell to the patient, it's an order. But yeah, Anna, this is how the management. If you want, you can, or others you go somewhere. So that is not the practice in world. The world has changed. So now the Sri Lanka was horrible economically. Now you know what has happened. One day the changes will occur. Now everything changed. Maybe after 2 years, Sri Lanka will be like another country in economic wise. The same thing will happen in the medicine as well. Once the lawyers start to file the case against you, then the medical system will change. And if you are trying to do a migration or maybe a licensing exam without knowing this, you can't. If you are trying to do the postgraduate without knowing this, you can't. So they are going to target those things to the doctors so you all can attend. So I think that lectures will be conducted maybe 15. I will confirm the date and let you know. One of the doctor from UK, Wafa something, I forgot her name. She's in senior registrar or something, consultant in UK. So she's going to do that lectures. So the geriatric consultant is going to do like ethical consideration in medical practice. So if it is a unconscious patient, when to escalate the things, when to stop resuscitation, those kind of things. So like that, every week, 2-3 lectures they are going to conduct as a medical educational program, right? So that is targeting for all the doctors in Sri Lanka. So everybody is going to come to Maura Education to learn these things. So what I want to do, I want to share these things to you. So please, even your juniors, they can attend, they can get to know those things, because after finishing this ERPM, if you want to do the PLAPO, USMLE, you should know these things. All right. So, and of course, once they provide these CPD courses, please attend. So that is going to be mostly going to be a free classes, free CPD classes. So when you attend those classes, you will get a CPD certificate. So you can get print out and keep with you with your CV. Then that is your CPD points. You have to add your CPD points. So now, if you work in UK, obviously there is a minimal CPD points you need to gain every year to maintain your GMC registration. You need to attend certain number of classes to gain that CPD points to keep the GMC with you. But in Sri Lanka, it's not like that. Once you fight and pass the ERPM exam, once you get the SLMC number, until you die, you don't need to learn anything. So most of our general practitioner, most of the doctors, it's very sad to say, still they are in ampicillin era. They don't know after that, right? So if they wake up and ask, oh, J.R.J. Othanais died, oh my God, like that. So they are in that ampicillin era because they don't know what is happening in the world, right? Because our system is that. So you can't be like that in future. So the medicine is changing. So you need to get updated by yourself to maintain your SLMC registration number, right? Because now in if you come to UK, when you have chat, then they are talking about the SLMC registration system. You people are not updating. Now that pressure will make the SLMC to introduce the appraiser, introduce the CPD. So even next month, they might introduce the appraiser and CPD, then you will be in trouble. So you need to update. You have to be prepared for that. So this is the most information you need to tell. So please add your seniors, your juniors to the group, and please join to that classes. So if you join to those classes when you register for the particular course, so obviously those classes will be available in Maura anytime you can watch. But some CPD classes you have to attend lively. So when you attend, you will get that certificate as well, CPD certificate. So mainly these lectures will be conducted by the foreign lecturers, sometimes some local lecturers and professors, right? So some lectures by me as well, okay? So maybe it's obstetrics, some topics will be conducted by myself because I'm one of the committee member on that educational activity. And one more thing, if somebody willing to work as a volunteers with our educational team, you are welcome to organize this class, right? And registration. So you will get, the benefit is you will get contact with these overseas lecturers and consultants and all. So yeah, you can work as one of our team member for the continuous educational program activities. Yeah, you are welcome. So you can contact me, then I will forward your CV and you can work with us. You all are welcome as my students. Okay, any questions? Shall we move to the history taking? Any question? Dilshini? Any question? No? Right. So we'll move to the history taking. We'll do some history taking here. Right. Okay. Now, this is the common format. Before I start the history taking, I teach. So when you take the history taking and presentation, okay, history taking and presentation. So I'm always telling, so this is a patient, this is the presenter, right? This is the presenter. You are here. So what you do is you take the history from the patient and present to the examiner or your consultant. So the history taking can't be an journalist history taking. I'm always telling that because most of the time when we take history, when we present the history, what we do, we are just asking from the patient and translate to English and you present to the examiner. So this patient is having heavy menstrual bleeding. Whatever the shit patient is telling, you are just telling the same story to the examiner. Whatever the shit. She went to toilet yesterday and after that somebody came to home and she washed her hand and prepared tea and gave it to the visitor. It's not. So you should know, patient might tell a lot of stories. You should know what are the things I need to tell. Sometimes when the patient is talking, the patient is telling, you should be able to stop the patient and ask your relevant question. Right? So you are not a journalist history or journalist to present the history directly from the patient to examiner. So whatever the shit patient is telling, you can't translate and present to the examiner. Okay. So what you have to do, you have to do some process before you present. So I am always teaching you some techniques like the open question and closed question techniques. Right? That is the most important thing, open question and closed question techniques. So if I tell that one right now, you might not understand what is that open question, what is that closed question, but I will tell you a few things. But when you attend to my classes, then you will get to know what is that open question, what is that closed question. Right? So the open question is like, now, okay, before we come to the open question, closed question techniques, I will teach you the process. What are the things you need to do before you take the history and present. Here, if the patient is here, if the examiner is here, whatever the patient is telling, you can't present. You need to do the process. So I am always telling one example because it deeply fixed in my mind. One student present a history like, I think it's 2017, yeah, well ago, but still it's in my mind. So when I asked the student to take the history and present, he or she, I forgot, that person is presenting like, sir, she had a heavy bleeding and she went to Castle Kalbo, what is it? DMH hospital, and they did the scan. They said it's normal and they have given 2 tablets. Patient is not aware about the tablet, and with the tablet, the bleeding has settled. And after 3 months, again she developed bleeding, and she came to Castle Street Hospital. Again, they have done the scan and they reassured it was normal, and they have given another tablet, but she's not aware about the tablet, and she was fine for 6 months duration. And again, she had a bleeding. She went to Kalubowila Hospital, and they have done the MRI scan and something like that. And now she again come with the bleeding. Okay, what is your diagnosis? Whether she went to Castle, whether she went to DMH, whether she went to Kalubowila, whether she went to toilet, I don't mind. It will not give any information to diagnose the disease. It will not give some information to manage the patient, isn't it? So, of course, only information I know from this, she's having problem because of the heavy bleeding and she's seeking medical advice in several places. That is the only information I gathered. But that information will not help me to diagnose the disease. So I need to understand what is a real problem, what could be the reason, and some information which happened in Kalubowila, which happened in Castle, which happened in DMH might help me to plan out my further management. Say, for example, if you are suspecting it is a fibroid or polyp, if she had a scan 2 months ago, or if she had a pupil biopsy or DNC and histology 2 months ago, will you repeat the histology? You don't need to, because she had a biopsy 2 months ago. So you can avoid some kind of things by those information. But where she went, those kind of information will not help you to find your entire diagnosis. Of course, you need to know those things. What happened up to now? Since her problem start, what are the things happen? That is part of your history taking. That should not be your history taking. So most of the students, what they do, they are just asking about what has happened up to now. That is their history only. It's not. So that is part of your history taking. So always when you come to my history classes or viva class, I teach you. So I will teach you, you will get to know. So what has happened up to now will be the last part of your history taking. Before that, you need to ask your history taking, because this is your exam. You need to diagnose. You are not here to tell someone's diagnosis. If a patient got admitted for the hysterectomy, you can't tell, sir, this patient got admitted for the hysterectomy. That is the presenting complaint. If admission for hysterectomy is the presenting complaint, then how can you diagnose your disease? Sir, patient got admitted for the hysterectomy. She had a heavy bleeding. DNC done. Endometrial hyperplasia. That's all. What are you going to tell next to the examiner? Nothing. So here what you want to tell is, sir, this patient basically had heavy menstrual bleeding for 2 years duration, and describe the bleeding, exclude your differential diagnosis, tell your possible diagnosis, then finally you need to tell what has up to now. So these are my possible diagnoses. She seek the medical advice 3 months ago, and they have done the scan, and scan shows like this, and according to the patient, they have done the biopsy, and biopsy shows some abnormality, probably a hyperplasia, and she got admitted today for hysterectomy. That should be the last part. Here you are telling that as a last, because you are not here to tell someone's diagnosis and someone's management plan. When I was in my part 2 exam, so they did the mock exam before the final exam. They have given one case for me. A patient got admitted to total abdominal hysterectomy plus bilateral salpingo-oophorectomy due to severe endometriosis. She's a subfertile patient, 39 years, severe dysmenorrhea, dyspareunia, can't tolerate, extensive endometriosis. So that's why they have decided, it was in the perineum, they have decided to go for a hysterectomy and bilateral salpingo-oophorectomy. The patient who got admitted to the hospital is for the hysterectomy and bilateral salpingo-oophorectomy. The problem I have identified is extensive endometriosis, primary subfertility, and heavy menstrual bleeding. So the reason for the admission is TH-BSO. But when I present the subfertility and endometriosis history, and I was discussing with the examiner not to do hysterectomy. My management plan is give GnRH for 6 months duration, suppress the endometriosis, do IVF, make her pregnant, deliver the baby, then decide the management. Yeah. Because that is one of the consultant management. That is not the standard management. You are not supposed to tell that management, because she suffered. So in my assessment, her problem is subfertility and endometriosis. Subfertility and endometriosis, you can't straight away think about hysterectomy, or sometime you might think about the hysterectomy. Never mind. But my management plan is this. So I argue, my discussion was like that. So I was telling the reason why I want to do this. So what are the possible outcome? What are the possible complications? What I am expecting? What is the outcome of the patient? So everything I discuss and rationalize my management. Actually, the examiner was impressed. Fantastic. Yeah, that's good. So because I'm not supposed to tell this patient got admitted for the hysterectomy and bilateral salpingo-oophorectomy, and I'm going behind that management. I'm not going behind that. You are not supposed to go behind someone's management. You are not here to tell someone's management, because you are not journalist. Journalists are the people tell the management of someone's. No. Here you need to diagnose, you need to plan your management, you need to discuss your management about your patient. So the second problem most of the candidates do, to answer like a hypothetical way. So if the patient presented with heavy menstrual bleeding and if not responding to medical management, I will do hysterectomy. Oh man, why are you telling hypothetical? Your patient is in front of you. Your patient receives some medical management. So you have to answer, sir, Dilshini received medical management, it's not responding, and she's suffering, it is affecting her day-to-day activity. And I discussed with the Dilshini, she is willing to go for a hysterectomy. I explained her about the outcome of hysterectomy, complication of hysterectomy. With the discussion, my management plan, hysterectomy would be the best option for her. There is no if here, because your patient is with you. You have to tell the management of your patient, not the hypothetical management. There is no if. Why you want to say if? If you are saying if, then why you want patient? They can ask, okay, can you present Dilsini heavy menstrual bleeding? Then you can present a hypothetical history and hypothetical management. You are not here to tell this hypothetical management. It's a tailor-made management. Take the history, assess the patient, and present your history according to your patient. So now, the students who studied with me and who are working currently as a house officer might realize, isn't it Abira? So now she's a house officer and getting good name among the consultants because, yeah, they studied with me. They know how to assess the patient. They know how to manage the patient. When you go to the clinical practice, that time you will realize what we have studied is correct. There is no hypothetical way. There is no hypothetical way of answering. Right? So you have to manage, you have to tell your answers to your patient. So there is no way to present the history directly with the translation. So here there are things called some process. The first thing I would teach, so this is the patient, this is your examiner. You are not supposed to present the history directly to the examiner by translating. Here, what you want to do first, when you ask some question from the patient will tell something. First, you need to translate it. Maybe because if you work in UK, you don't need to translate because patient will tell the history in English. But if you work in Sri Lanka, patient either might tell in Sinhala or Tamil, so you need to translate it. So patient is telling, so bleeding. So then, okay, translate. So the problem is she's having bleeding, heavy bleeding. So yes, translated. Second thing, you need to interpret it. What do you mean by interpret it? Because when the patient telling heavy bleeding, do you believe it is always correct? Yes, Shashika, do you believe it's always correct? No. Why it's not correct? And I forgot to tell, please, this is the Viva class. Here, not going to be the lectures. You all have to talk to me, isn't it? Because you are going to present to the examiner. So this is the practice class, isn't it? So today, obviously, it's a free class. I'm not going to force you. But when you come to the paid class, I will make you to talk. Otherwise, it's no point of coming to my class. Okay? Okay, Shashika, are you ready? Okay, just tell me. So why always it's not correct? Any idea? It could be right, it could be wrong, doesn't matter. Everybody do mistakes. Any idea? Dilshini, whoever. It's an objective, right? Sometimes you might, so it's a personal perception. So sometimes, so when I'm asking Dilshini, oh, okay, how is your observant gynae teacher? Is he fair? Then Dilshini might say, no, he's dark, no. But Sasika might say, oh my God, he's fair, no. Ooh. It's an objective. So it's personal difference, isn't it? So everybody will tell in a different way. Yeah, he is. So for someone I might be very dark, someone I might be dark, someone I might be fair. Yeah, agree? So when you talk about the pain, when you go to the labor ward, everybody is laboring. So some women, they are nicely sleeping and deliver the baby. Some are making noise, ooh. Some are screaming and dancing. So are they having a different process? No. Everybody have same uterus, everybody has uterine contraction, everybody in labor, everybody is delivering the baby. So the screaming lady is not delivering anything different. So she also going to deliver the baby. Same process, same physiology, same prostaglandin, same oxytocin. Yes or no? But why one lady is screaming? Why one lady is not normally crying? Why one lady is enjoying? It's a personal perception. So that doesn't mean you can't say that lady is screaming, so she's acting. It's her tolerance. Most of the time, when you start working in obstetric ward, most of the midwives, especially, that's why these women like male obstetrician than female, because these female obstetricians or female doctors are comparing the pain with them. Right? So they are telling, so most of the midwives are telling, see, I also deliver the baby, I know the pain, don't act. No, man. You did the delivery, you had the pain, your pain tolerance is different from another person's pain. So if somebody is screaming, that doesn't mean she does not have pain or she's acting. She's having pain, that is a pain tolerance. Somebody is not having pain, that doesn't mean she does not have pain, her pain tolerance is poor, very good. So when somebody is in pain, you have to respect them, you have to accept them. Yeah, of course, because she never felt pain, or she might have low threshold for the pain. You got the point? So this is an objective thing. Everybody might say in different way. So some ladies, because it's a clinical practice, some ladies might say, doctor, I'm having heavy bleeding. Oh, heavy bleeding. Yeah, it's very heavy. All right, okay. So then you're just doing MRI, pelvis, CT, ultrasound scan, and you do everything. But when you take the history, it's really not heavy. Okay, just tell me how heavy it is. I'm changing 5 pads. Are you passing clothes? No. How many days? 5 days. Some women might say, no, look, I'm changing 15 pads. Oh, if someone is changing 15 pads, it's heavy. But if you really ask that question, she said, no, doctor, every half an hour I need to change because, I feel discomfort when there is a pad. So then every half an hour I go and change the pad. So that doesn't mean she's having heavy bleeding. So the number of pad is not going to tell you whether it's heavy or not. So it's a personal perception. So when somebody tells some story or some symptoms, the first thing as a medical professional, you need to clarify whether it's really a problem, really a heavy, or really an abnormal. That is the first part. Even peptic ulcer symptoms, they might say chest pain. Musculoskeletal pain, they might say chest pain. So this is your duty to interpret that one. So the first thing is interpretation. You need to interpret the symptoms. Is it really a heavy bleeding? Is it really a heavy pain? That is your first task. Interpret the symptom. Yeah, you have asked a couple of questions, maybe 4 or 5 questions, and yeah, it's really heavy bleeding. So we will study what are the questions you need to ask to confirm the heavy bleeding, what are the questions you need to ask really a heavy pain. There are certain questions. We are going to study those things in the viva class. So when you ask that question, right, you are quite sure, yeah, this is really a heavy bleeding. When it is a heavy bleeding, obviously, you start to think why it is heavy. What could be the reason? Could it be a fibroid? Could it be a malignancy? Could it be a polyp? Could it be a hyperplasia? What could be the reason? I don't know. So now, first thing, you need to interpret the symptom and identify whether it's really an abnormal or not. Yeah, of course, it's abnormal. So the second question, what is the reason? So you need to analyze the symptom. What could be the reason for the heavy bleeding? You are analyzing. Right now you have analyzed and you have an idea, okay, it could be due to fibroid. It could be due to polyp. It could be due to hyperplasia. If you know this cause, once you analyze, now after analyzing the symptom, you can't directly present. Still, you need to organize your history, because when you take the history from the patient is telling in haphazard manner, right? So she's telling something here, there. It's not in a chronological order. So your history should be in chronological order. What do you understand by chronological order? So time manner. So this lady attained menarche at the age of 13, and she had a regular normal flow till the age of 25, and she got married at 26. She got her first baby in year time without any complication. After that, she used IUCD for 3 years. Now, last 6 months, she had irregular heavy menstrual bleeding, which is affecting her day-to-day life. So it is a chronological order. And I know her menstrual history now. What has happened over this period, her reproductive age. This is called chronological order. But when you take the history, patient will not start the history from menarche. When you ask, Amma, why did you come? Doctor, I attained menarche at 13. Then my period was normal. Patient will not tell that. Isn't it? Will you expect patient will tell like that? No. Patient will start with the bleeding. Then you have to ask, okay, Amma, have you married? Yes. Do you have any kids? Yes. How many? 1. Are you using any contraception? Yes. What is that? IUCD. So you have to gather all this information. This information science scattered manner. Then what you want to do, you want to organize this history. So I'm going to teach you how to organize this history. That is the reason you are here, not to give that history format. Okay? So I will teach you how to organize this history. So organize the history. Once you organize, you are having chat with the patient for a long time, isn't it? 30 minutes, 20 minutes, but your presentation time is 3 minutes. So it means you are not supposed to tell to the examiner everything what you have had chatting with, what you had chat with your patient, isn't it? You are not. So you need to know what I want to tell, what should not I have to tell to the examiner. So what you want to do the next part? Yeah, Dilshini, what is the next part then after organization? Shashika? Any idea?
Examine the patient.
No. What I'm asking is, so you are translating, interpreting, analyzing, organizing. Then what you want to do next before you present? You have to summarize it. Summarize it. Right? You need to summarize. Without summarize, you can't tell whatever the things you have had a chat with the patient. So then summarize. And after that only you can present to the examiner. So here this analyzing, including your history taking, examination, everything included with your analysis. It's not only the examination, history taking. This is before you present, you have to do all these process. You are translating, interpreting, analyzing with the history examination. Then you organize your history examination and summarize your history examination, and finally you present to the examiner. So most of the students, what they do is this way. They just talk to the patient and straight away present to the examiner. Hello, Amma, how are you? Sir, she came out. So you are not doing that. Right? You have to go through this path rather than going this. So if you present like this, definitely you will fail. Why you people are doing this? Because of the wrong way of teaching. Because what I have noticed over the period, and I changed my teaching way, because most of the time we are talking about case based. Machan, what is the case for you? GDM, Machan. Fibroid case. Past section case. So what is happening? They are teaching you, oh, you are studying like this, GDM case. And you have a history format for GDM. And you are memorizing the stuff what you want to ask for the GDM. And when you get a patient with GDM, you just ask few questions which you have memorized already, and you present to the examiner. But in practical, you don't have patient with GDM or GDM case. Here, there is a woman with some problem. So most of the time in your exams, your patients will have more than one problems. So the history taking and assessment should be problem-based history taking, not case-based history taking. Please forget about that. So because few students are asking, sir, some teachers are doing 5 classes. Why in 5 classes I can do some case formats and give it to you? I just read and you will memorize and you just present those cases. You will fail. It is not case-based discussion. It's problem-based discussion. So when there is a pregnant mother, you have to identify what are the problems she's having. If she's having hypertension, that mother has high risk to have IUGR as well. So when she has IUGR, which case you are going to present? Hypertension case or IUGR case? Because you have a history format for IUGR one paper, hypertension another paper. Which history you are going to take for this patient? Hypertension or IUGR? Which one deals in it? There is a patient with IUGR and hypertension. Which history you will take? Hypertension. Which one you will take? There is a patient with hypertension. Sorry?
Depends on the case.
Yeah, this is the patient. Patient had a hypertension and baby is small. What is depends? Here, which history you are going to take? Hypertension history or IUGR history? Tell me.
Hypertension patient.
So then, if the examiner asks about the IUGR, what are you going to tell them?
You should take, like, you should gather both information.
Okay, so you want to take both history format?
No, sir. It depends on the, like, you should have the idea about both.
Okay.
You shouldn't stick to one case.
Okay.
It depends on the way we should take the history.
Okay.
Gather information, I guess.
Yeah, gathering, that's what I'm telling. Yeah, thank you for answering. That's what I'm telling. Here, when the patient is having 2 problems, 3 problems, if you go with the history format for the hypertension, history format for the IUGR, because you studied for the case-based studies. Hypertension case, you have a paper, you know, you memorize some question for the hypertension. So when it is hypertension, you can ask that questions only. So your 7 minutes is enough to ask only the hypertension. Even you are struggling to take hypertension within 7 minutes, how can you take hypertension and IUGR? I mean, most of the time, so hypertension, second pregnancy, IUGR, also she had a past section. What are you going to do now? And at 28 weeks, her hemoglobin is 8. Done. So you can't tell to the examiner, sorry, sir, actually I took the anemia history. You just ask whatever the question in anemia, don't ask from past section. So you can't tell that. So here, that's why I'm telling, when you study, when you present, or when you prepare for your exam, never ever go behind the case. There is no hypertension case. There is no IUGR case. There is no past section case. There is a pregnant mother. So what is the aim of the candidate? What is the aim of the candidate? So there is a pregnant mother. She has hypertension, IUGR, past section, and anemia. So I'm the examiner. What I am expecting from you? Shashika, what I am expecting from you? There is a patient with past section, IUGR, anemia, and hypertension. I'm the examiner. What I am expecting from you? My expectation is whether you have identified all the problem which she has. That's all. I don't mind whether you took A to Z from hypertension, A to Z for anemia, A to Z those things. So here the problem identification, problem-based history taking. So I will teach you later. So maintaining those box, and when you ask every questions, you need to identify the problem. And whenever you find the problem, you need to ask some certain important questions related to the problems. Because when there is a hypertension, I know if it is a PIH or chronic hypertension, one of the complication is IUGR. For that mother, you don't need to exclude small for gestational age, possible causes are wrong date, abnormal line, or constitutional small baby. Those kind of things you don't need to exclude as what you studied. Because it's hypertension, you are expecting IUGR, so you can tell as a complication in a nice way. So my patient in her second pregnancy with previous pregnancy complicated with pregnancy-induced hypertension and delivered by cesarean section due to preeclampsia at her period of gestation of 35 weeks. This time in her second pregnancy admitted to the ward with elevated blood pressure at a POI of 34 weeks. Now with an introduction, you have given most of the information to the examiner. What are the information you have given? Past history of PIH, preeclampsia, past history of section. This time admitted with preeclampsia at 35 weeks. So now you have given the information. This is the planned pregnancy. You can tell nicely. This is planned pregnancy. So here you are applying your background knowledge. Past history of preeclampsia is an indication for aspirin. So always you need to tell that to the examiner. This is a planned pregnancy and booked her booking visit at 12 weeks and she received aspirin since her 12 weeks of period of castration. Now you are showing to the examiner, I know the fact. I'm looking for it. Because if you are my house officer, that is my expectation. When you become a house officer, when you see a patient with previous history of preeclampsia, you have to start aspirin to prevent the preeclampsia this time. If you don't know that, if you're asking all kind of dietary, what you are eating, morning what you are eating, evening what you are eating, and spending too much of time for the diet, it's not going to work here. Because here you have to ask, okay, Amma, right. So you said your hemoglobin was 8, right? Have you received any blood transfusion? Have you taken iron tablet? Are you taking regularly? Have they taught anything about the dietary advice? So just ask 2-3 important questions and you can say, she found her low hemoglobin, but no history suggestive of blood transfusion on oral iron therapy, good compliance, and she's aware about the dietary advice or dietary pattern for anemia. That's all. Because you have so many things to tell to the examiner. So the way you are presenting, the way you are assessing, when you are taking the history, usually your history taking is observer history taking. The way you are taking the history, examiner will realize, yeah, this candidate is fit to pass the exam. If you want, please, you just ask your seniors who studied from me, what has happened to their exam? How the examiners were reacting or gave the response after the exams, because that is how I am training my students. So it's a targeted history taking, problem-based history taking. Never ever target the case-based history taking. That is the very wrong thing always you do. Problem-based history taking. PIH case, GDM case. I don't know. It could be correct for medicine or surgery, not for the obstetrics or gynecology. Because obstetrics and gynecology, it's completely different subject from the other subjects. Because I'm always telling you, if a patient presented with chest pain, you have sort of differential diagnosis. Definitely, it could be a MI, pneumonia, peptic ulcer disease, or maybe pancreatic disease, or maybe musculoskeletal pain. Other than that, nothing. Could it be meningitis? If somebody present with chest pain, could it be meningitis? Could it be rheumatoid arthritis? Huh? Could it be? No. Obviously, no. Because you have limited differential diagnosis here. But if someone is presenting with joint pain, then we know what are the differential diagnoses. Then you can't say it's a lung cancer. You can't say it's a brain tumor. For the early morning stiffness and joint pain, you can't say it's myocardial infarction. Because it's systemized. For medicine or maybe surgery, you can tell this is a MI case. That could be possible. I don't know. I'm not masters in that. But in obs and gynae, you can't tell that. Because always I'm telling, if it is a gynae case, what is the presenting complaint? Almost 90% of gynae case will present with one presenting complaint. What is that? What is that? Vaginal bleeding. If it is a vaginal bleeding, even miscarriage, vaginal bleeding. Antepartum hemorrhage, vaginal bleeding. Cervical CA, vaginal bleeding. Endometrial CA, vaginal bleeding. Ovarian CA, vaginal bleeding. Fibroid, vaginal bleeding. Polyp, vaginal bleeding. So all the cases present with one presenting complaint. So if you have different presenting complaint for different cases, it's not that much difficult you to diagnose. But one presenting complaint for all kind of cases, it's very difficult. Could be a pregnancy, could be a malignancy, could be a benign. Anything possible, but only one symptom. What is that? Vaginal bleeding. So it's not easy as you think. Most of the students are thinking the vagina and the uterus is very small. These obs-and-gynae people are dealing with only a small area. That is the dangerous area, you know. All the problem is there. It's difficult to understand. You can't easily understand. So you need to have a good common sense to understand the disease. So if it is a vaginal bleeding, you need to sort out. Could it be a malignancy? Could it be a pregnancy? Could it be a benign cause? Could it be a fibroid? Could it be this? Could it be that? So you need to sort out. So when you list the differential diagnosis for the vaginal bleeding, entire condition will come. Then you need to sort out everything within that short period. So if it is a pregnancy history, here there is no presenting complaint either. It's a pregnancy. As I told you, you can't present one case as well, because one pregnancy might have so many complications. Isn't it? One pregnancy might have so many complications. Could be fibroid complicating pregnancy. Could be GDM, PIH, because everything is interconnected. If a mother has GDM, that is risk for the PIH. If it is a PIH, that is risk for the IUGR. If it is an IUGR, that is risk for the placental abruption, preeclampsia. So it's interconnected. So you will have so many problems in one patient. So your history taking should be a problem-based history taking rather than his-based history taking. So always you need to identify the problem. That is your first thing. Second thing, always you have to anticipate complications. So anticipate problem. That is the most important thing in obstetrics, because the simple question I'm always asking from my students: pregnancy, is it a disease? Is it a disease? Telshini, is it a disease? What do you think, Shashika? Pregnancy, is it a disease? Pregnancy, is it a disease? So then, if so, then just imagine you are giving huge amount of dowry to get that disease, isn't it? Millions of money, car, houses to get that disease. Habib, if that disease not occurred, then we are spending too much of time to do the IVF to get that disease. Is that so? So pregnancy, it's not disease, it's a physiology. So even though it's physiology, why are we worrying too much about that pregnancy? What is our concern? Why are we worrying too much for this pregnancy? What is the reason? What is the reason? Because pregnancy is like a time bomb. Anytime. So like your girlfriend, any moment it might convert it as pathology. Anytime. So until this moment, this pregnancy is uncomplicated. Suddenly, placental abruption, cord prolapse. Now it's pathology. Until she delivers, there is no problem. After delivery, shoulder dystocia, pathology. After delivery, she started to bleed, pathology. So anytime this pregnancy can convert it as pathology. So every moment, a woman registered under me in a booking visit, that is the headache for the VOG until she delivered and her postpartum is over. Because anytime she can convert it as complication and maternal death and will affect my career too. Right? So I'm not sure what will happen to her until she delivers the baby and even after the postpartum period as well. So anytime this pregnancy might convert her to pathology, I don't know whether she will develop PPH, whether she will develop shoulder dystocia, whether she will develop placental abruption, whether she will develop GDM, whether she will develop PIH, whether she will develop DVT. It can convert to pathology at any time. How do you know? Can you predict? Is it possible to predict, Sashika? Is it possible you to predict whether will it complicate or not? Can you anticipate any complication in pregnant mothers? Yeah? Can you? Sashika? Dilshini? Can you? Yes, you can. You can anticipate. How can you anticipate the complication? By identifying the risk factors. If a mother had diabetes, she has risk of shoulder dystocia. If a mother had previous PPH, she has risk of PPH in current pregnancy. If the mother is elderly, she has risk of PPH in consequent pregnancies. If the baby is larger, risk of PPH. Prolonged labor, risk of PPH. Induction of labor, risk of PPH. What you have studied in the theory will useful for you to predict your complications. So your history taking to target the problems, identify the risk factors. See how nice it is. So then only you will be a good obstetrician and gynecologist. Always you need to identify identify the risk factors and you need to predict what will happen. What is going to happen with this pregnancy? What is going to happen with this lady? So, and identify the risk factors and anticipate complications. That is your second part. And third part, identify the complications. So already she might have some complication like anemia. If it is a twin pregnancy, she might have anemia. She might have PIH. She might have GDM. So always you need to ask few questions to identify those complications. So if it is a twin pregnancy, always you need to ask, Amma, have they done the blood test at 12 weeks, 20 weeks, 28 weeks? Why? Because we know she's having risk of anemia. That's why we are doing screening tests on this period of gestation. So don't worry, I will teach you these things. So if she has anemia during that time, then I can say, yes, as you anticipate, she's having anemia, isn't it? As you anticipate, she's having anemia. So always you need to think about that. So identify the problems, identify the risk factors, identify complications, and with this list, you can anticipate the problems throughout the pregnancy. Now, this is a PIH patient with previous preeclampsia. So now you have two risk factors. One is previous preeclampsia, second, current pregnancy-induced hypertension. So she's having high risk to develop preeclamptic toxemia in her pregnancy. She's having high risk to develop placental abruption in her pregnancy. So you are anticipating that. You can advise the patient, Amma, anytime if you develop headache, blurring of vision, right hypochondrial tenderness, angle swelling, immediately you need to come to the hospital. Why? Because you are anticipating preeclampsia. You got the point. So if you do the practice like this, if you take the history like this, it's easy to manage a pregnant mother. It's easy to present a pregnancy history. But I'm quite sure if you are not practicing like this, obviously, if you come to my viva class, I will train you like this. So at the end of the class, you all will take the history in this way, not in case-based history, because my way of teaching is completely different from others because I'm teaching in problem-based history taking. So then you can simply pass, except if you have some issues with language or something. Otherwise, you don't need to worry about passing the exam. Do you have any questions regarding the history taking or problem analysis? Or if no, then I can move to other few things. Do you have any questions? Yeah. Do you have any questions now? Any questions? Okay. So if you don't have questions, few words about the obstetrics. In obstetric history taking, first of all, you need to know few terminologies like LRMP, last regular menstrual period. EDD, expected date of delivery. Right? So POA, period of amenorrhea, or POG, period of gestation. So here you expect you to calculate the EDD, calculate the period of gestation. That is must. You can't ask from the patient, Amma, how many weeks you are, because patient it's not knowing to calculate the period of gestation. So you are supposed to calculate the period of gestation. So in obstetric history taking class, I will teach you how to calculate the POA, how to calculate the EDD and things. And in Sri Lanka, we have formulated antenatal care. So set of practices there in Sri Lanka. So it's simply you can ask certain questions, because if somebody married, so we register to the eligible couple registry, then the midwife will give folic acid. Then once they become pregnant, they will register to the midwife. Then they will have a first booking visit. In first booking visit, they do certain things. Then from second week, they take the nutritional supplementation and vaccinations, tetanus toxoid vaccinations, and quickening, anomaly scan, symbiofunnel height measurement, then routine ultrasound scan, clinic visits, OGTT and diabetes screening at 28 weeks. Those kind of things are already formulated. So if you know that, that will be easy for you to ask questions from the patient. So I will teach you what are the formulated things you need to ask in a pregnant mother. Okay, right. So do you have any questions? If so, almost now 11:30. Yeah, I can see most of the people switch off the camera, and I don't know whether they are sleeping or not. Even I'm teaching to the sleep student. I don't know. Hi, Asfaq. How are you? All right. I'm pretty sure you are not sleeping, obviously. Yeah. Any questions? Any question, Ahmad? No. Crystal clear. So we'll start our class on Saturday, 12 o'clock. Yeah, that would be better. We'll start at 12 o'clock, and we'll do this case discussion and as well. So you all can access those classes to the More Education. If you have any question, you can ask. I'll upload this class to the More Education Viva class, free class access. So you can access, if somebody missed the class, you can access those classes. Yeah. So I will let you know about the clinical session as well, and we'll do the case discussion. So if you have any questions, you can contact me through WhatsApp, or you can contact my coordinator. If no question, we can stop the class, isn't it, Dilshini? And please add your juniors, seniors, and your batchmates to your relevant university group, or maybe my WhatsApp group, or maybe my Telegram group, or just ask me. I'll send the link so you can add them. So after 15th, we are going to start that educational program, so that will be useful for everyone. Okay. Okay, then. So you all can have a nice night. So we'll see you on Saturday. Have a nice day. Good night.